This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
The McCormick Place Convention Center in Chicago is packed with cardiologists and scientists as they gather to hear about the late-breaking clinical trials. Welcome to CardioSource Video News. I'm Dr. Randy Martin. The American Heart Association Scientific Sessions 2010 are in full swing today here in Chicago, and we have some very interesting trials to talk about and an impressive panel and an equally interesting panel to discuss them. I'm joined by Dr. Christopher Cannon. Chris is Associate Professor of Medicine at the Harvard Medical School and Brigham and Women's Hospital, plus he's also Editor-in-Chief of CardioSource Science and Quality. And Dr. Tony DeMaria. Tony's Professor of Medicine at the University of California in San Diego and the Editor-in-Chief of the Journal of the American College of Cardiology. You know, first we're going to talk about the Rocket AF trial. Now, anticoagulation with warfarin has been the key therapy for preventing strokes in patients with non-valvular atrial fibrillation. But as we all recognize, there are challenges with its routine use, and that's led to the development of some new types of anticoagulant therapy. So Chris, let me turn to you and say, tell us a little bit about the Rocket AF.
Well, this is a very exciting area. It's been more than 50 years that we've been struggling with warfarin. Every one of us has to, manage this. And so the Rocket AF studied an agent that's an oral factor Xa inhibitor. This one is rivaroxaban, and studied in the non-valvular atrial fibrillation to look for stroke or preventing systemic embolism. So very exciting trial, 14,000 plus patients that met its primary endpoint, that it showed that rivaroxaban was officially non-inferior or as good as warfarin in preventing stroke or embolism.
And Tony, the only anticoagulant you and I've ever known since medical school has been warfarin, basically. I mean, what's your take on this?
Well, as Chris said, warfarin has truly been a hateful drug. Lots of INR blood draws and whatnot, and so any advance in that area has been enormously welcome. And rivaroxaban certainly is as good. No additional bleeding, once a day, no INR.
No INR.
Single dose, and so all of that's enormously attractive. It would have been so much nicer if it was even superior to warfarin. Right. And of course, dabigatran was in an earlier study, and so these two drugs are going to cry out to be compared.
Yeah, I mean, do you think, we all struggle with, obviously, the use of warfarin and, and food interactions, patients taking the drugs, those sort of things. Do you think this is good? These types of agents are going to change our practice?
Oh, definitely. I mean, it will be a transition, but I think one of the advantages, interestingly, that's been seen in both trials is the lower rate of intracranial hemorrhage.
Right, that's a big deal.
And of course, that's the thing we worry, what's a patient's risk of falling? And I think, although it's not fully worked out, that the variability of the level of anticoagulation in the INR could be that you get a bleed when the INR gets out of control high. And with these medications, they provide a more steady level of anticoagulation. So that is obviously very reassuring to avoid one of the biggest fears we have. And of course, stroke is, a devastating and disabling problem, so that helping avoid that can be key.
And looking at the aging population, obviously the non-valvular AFib is going to go up higher and higher. And so, is this agent as safer? Those sort of things are going to be big.
Absolutely, and numerous studies have shown that most patients spend a fair amount of time with INRs out of the therapeutic range.
Absolutely.
And here I think we're going to avoid that, so lesser bleeds. Sometimes there's a new drug that's introduced and they have to create a market. There's no market that needs to be created here, boy. These drugs are going to be grasped with enthusiasm.
Yeah, I don't think, Chris, I'm sorry, go ahead.
Yeah, no, I think this is probably the biggest area for long-term treatment of non-valvular atrial fibrillation. There are many other patients that we manage that need warfarin. So valvular related AFib hasn't yet been studied. In theory should perform well. I think getting a dose sorted out. Mechanical valves have not been studied in any of the studies to date, and so we'll have to wait to see what that pans out. There have been a lot of studies with all the agents in DVT prophylaxis in people having orthopedic surgery, and then treatment of DVT and pulmonary embolism is the other big one, and trials are just starting to come in there. So we're starting in. We have the other agent, dabigatran, that's just recently approved, but we're entering a new era.
Yeah, no, I think it's very, very exciting. It's probably going to change our whole practice routine. So we're going to be back in just a moment. Stay with us.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource Video News at AHA 2010. This is CardioSource Video News coverage of AHA 2010.
Welcome back. There were a series of special reports released today at the AHA Scientific Session, and one of the most notable was the women's trial. Now, the women's trial looked at the effectiveness of simple exercise EKG compared to exercise EKG with perfusion scanning in women who were suspected of having coronary artery disease. I've already introduced Dr. Cannon and Dr. DeMaria, and joining us now is Dr. Deepak Bhatt. Deepak is Associate Professor of Medicine at the Harvard Medical School, and he's also Chief of Cardiology at the VA Boston Health System. Deepak, thanks for joining us. Tell us a little bit about the women's trial.
Sure. Well, I think this is an important study that took about 800 women and randomized them either to a strategy of exercise ECG stress testing or the same plus myocardial perfusion scanning. So these are low to intermediate risk women where these two strategies were compared. 2-year event rates were examined as far as major adverse cardiac events, and there was no difference in terms of MACE. So I think that's an important finding, perhaps a little bit different than at least how some of us might be practicing, the feeling that there are more false positive stress tests in women, and therefore we should go right to imaging with that first stress test.
Chris, that's what we've always been taught, especially a lot of these women were peri or postmenopausal, and so I think what Deepak is, that's an important issue.
Yeah, and I would say this is a terrific trial because it's an imaging strategy trial, and so wonderful, and looking at outcomes. So this is a big step forward in the field. It's a modest size trial, and there aren't many primary endpoints, so that it doesn't really exclude the benefit per se of a strategy, but to me says that it's okay probably to start with an exercise ECG stress test, and that was normal in 80% of the people, so that's a good starting place, and then one can obviously use judgment as to who you do imaging in or not.
Tony, comparative effectiveness test, but it also has economic impacts, doesn't it?
It had economic impact, and obviously if you add in the cost of a radionuclide study, it's going to be more than an exercise ECG. I guess we need to be cognizant of the fact that those patients who started off with a stress ECG that was abnormal often crossed over or went on to an additional radionuclide test. So as Chris says, it's a very good strategy to start with a stress electrocardiogram, even in women, and it will be cost effective. But there's going to be a number of women in whom you're going to want to go on to radionucleide test.
But I thought that if they had a negative stress EKG, and these are exercise, not farm stress, okay, and they did a fair amount of exercise, they had a good 2-year outcome. So that's a positive out of this thing, isn't it? I mean, wouldn't you say?
Oh, absolutely, and that's the point, to start off that way. But there are going to be. Okay. There are going to be a number of women who have positive ECGs who are low risk and asymptomatic, and I think most of us would go to another screening test rather than invasive coronary angiography.
Let me shift gears. That's a good summary. There was another study out called the PROTECT. Tell us a little bit about that.
Yeah, PROTECT's a very interesting study. It's again testing the concept of whether you can use natriuretic peptide measurements, in this case NP-proBNP, to better treat patients with chronic heart failure. And so they had a class 2 to class 4 heart failure group, and they were randomized, a relatively small number, 75 patients in each group, randomized to either standard therapy, aggressive standard therapy by heart failure experts, or standard therapy with BNP monitoring and an NT goal of 1,000, and followed those patients along. And the bottom line was the patients in whom they followed NT-BNP and treated them more aggressively received more drugs and had fewer events with the same amount of side effects, indicating, at least in this very small trial, that the natriuretic peptides can guide better therapy in heart failure.
Deepak, what's your take on this?
Well, you know, my gut feeling says that makes sense. I mean, it makes sense that if you're targeting this particular biomarker, it should result in improved outcomes. Now, of course, no one's really been able to nail that down until this study, so I think this is an important step forward in truly personalized medicine. However, it does need to be replicated in a larger sample, multi-center study, et cetera.
Chris, what are your thoughts?
Well, I agree. I think, you know, using the lung fields as the only measure of how well someone's diuresed is not a very precise measurement. So to have NT-proBNP to say, are we really getting the measurements down, and aggressive treatment, this gives us a way to truly monitor patients, and so very promising, makes really good sense. So, and it's easy to do, and so it really fits. I think I'm going to start doing this.
I was going to say, Tony, you think Deepak, you think it'll change our practice?
Yeah, we have to keep in mind that it didn't change mortality. But the groups were quite small, and it does have cost implications. Right. And in fact, what's very interesting, Randy, is the patients in whom natriuretic peptides were applied actually had more return visits than the other patients, because both would seem to be clinically stable, but you detect the elevated BNP.
And would that keep patients out of hospital then?
It did in this trial.
That's right. That's the key. Well, listen, thank you all for joining us, and thank you for joining us here on CardioSource Video News. Check in with us for updates on breaking trials and continued one-on-one interviews.